Sorry about that. So, macro hole surgery, it's also a minimally invasive vitreous surgery. That's what the concept is now, for excepting for a few cases where you might do an hybrid vitrectomy, where you have to remove a foreign body, or if you got a choroidal detachment with a retinal detachment, you want a 6mm cannula. In fact, I'd like to ask the panelists and the audience about 6mm cannulas in these 23 and 25 gauge systems, because there I use a 20 gauge 6mm cannula, and so that's a hybrid system. So the advantages are immense, and I think you all know that the scarring is less, the surgical astigmatism is much less, and we've got a UV cycle control in most of the newer vitrectomy machines, which you must be all aware of and must be using. That's the port is actually closed most of the time whenever you're shaving across the retina, so that's an advantage. And it also, there's a fluidic stability which is there, so IOP is well maintained, and there's less traction to the retina as you're moving along the surface, as just mentioned, so less break formation. So you can use 23, 25 and now the 27 gauge, about which we'll have some questions also. And surgery, successful closure could be because of the induced glasses by the surgical trauma of peeling the ILM, which is now thought to be part of the macular hole surgery, that you should peel the ILM. Various studies initially said that you may or may not. Maybe for tiny holes, stage 2 holes you may not, but for stage 3, 4 or large flat holes you may like to definitely peel the LM, because the surgical results are much better and subsequently visual results will improve. Green Blue G is now a very highly non-toxic dye as compared to the previously used indocyanine green and even the trypan blue dye, which stained the ILM very faintly, and we used to use triamcinolone crystals also. So one of our studies at the graphics showed that the Brill Blue G is a relatively non-toxic dye. It's injected under fluid, so not under air like trypan blue, and it's less toxic to the photoreceptor RP layer, has been shown in various experimental studies with ICG. ICG is thought to be very phototoxic dye. It stays in the eye for nearly 6 months to 1 year after injecting into the eye. So though it stains the ILM very well, it is the phototoxic. Brill Blue G basically takes over from that, and a short video will just tell you a few steps about this biplanar incision which we make with the 23-25 gauge systems. We'll ask our panelists what they feel about the newer system of 27 gauge and whether this biplanar incision would be of any role or not. But the biplanar incision basically ensures there is a pressure closure of the valvular entry, and so there is no fluid egress or any chance of any infection going in or the hypotony subsequently, and also to make sure that there is no choroidals coming up the next day. So, and this is just the ILM which is stained with Brill Blue G under fluid, and within a minute or two the stain is enough for you to go ahead and peel. And probably to peel across the hole, you remove the traction at the edge of the hole. Any traction or traction ring sometimes we see. So this is just to show you the procedure, and we'll go on further. We did some electron microscopic study to show that the ILM removal plays a major role in the closure of a macular hole. This is an electron microscopic study predominantly using, that time we were using ICG in 2005, and this is one of the fibrocytes. Yeah, pointer. This show fibrocyte within the ILM, excised ILM in electron microscopy, which we had also reported. So, low macular hole index holes are large flat holes. So, the standard to stage 2, 3, 4 holes may be having a maybe higher in height and small base diameter, so they are usually easy to close. But what happens if the height upon the base diameter divided by the base diameter is called the macular hole index? That's the B upon A. This is the B, the height upon the A is, if it's more than 0.5, the results are extremely encouraging. Less than 0.5 is what we say is a larger diameter or large holes. So there we've also done some cases, and this is just to show you, this is in the evolution that the macular hole forms because of the vitreomacular traction. And you can have type 1 or type 2 closure. Type 1 closure, there is no defect of the neurosensory retina. That's a complete closure. Type 2, there is a defect in the center, but the edges are flat. They're absolutely flat down. There's no gap between the retinal edge and the macular hole edge and the underlying RPE. So it's a flat down hole, but there's a gap in the center is in type 2 closure. The visual acuity results automatically are much lesser. But type 1 can be U pattern or a V pattern, depending on the type of pattern you see. So the lines are very important. So OCT plays a major role, and the ISOS line and the ELM are extremely important. You must be all knowing about those lines, and they say the continuity of those lines post-operatively helps you to give a possible indicator the patient is going to improve visual acuity. Especially the ELM now they say is very important. The ELM runs through the photoreceptor cell body. The photoreceptor integrity becomes normal after macular hole surgery, and they say that the visual acuity improves. So you should study these lines on the OCT. That's why these imaging modalities are very important. What we just discussed. This is a large flat old hole. So just do a little tapping on the edges of the hole. We presented this at the Asia Pacific meeting at Hong Kong, and subsequently published this data. This is to increase the height of the hole. This is after Peter Stalmans from Belgium, who has adopted this technique, and he just taps the edge of the hole without touching, trying not to touch the RP. So it's to increase the intraoperative height. The intraoperative OCT would play a major role in such cases to know what happens. The intraoperative OCT would also be a point which we'd just like to see and discuss. So this is just to tell you what the last slide is for tell you that positioning nowadays is not thought to be 3 weeks, 4 weeks. Patient gets discomforted when the surgeon tells him it's going to make you prone for 1 to 4 weeks, and then he's going to start thinking that should I get the whole surgery or not. So actually the hole closure, as described by Klaus Eckhart, who is one of the pioneering surgeons for macular hole surgery, and he's described it, and his Frankfurt retina meetings are extremely well attended from India also. He said the hole, if it has to close, would close in the first three days. And that's what I personally noticed also. So if you've got to give the positioning, the first 3 to 5 days, maximum 3 days, in the first 3 days strict positioning actually plays a major role in the hole closure. Thank you very much.